Hi, everybody. This is Erica Mello, and welcome to episode number 170 of Tough to Treat. And in this episode, is a shorty episode, actually, I address an email that was sent to me from a listener on a patient she was having an issue with. And it's a very short scenario. I didn't get a lot of information, but I thought it would be useful based on the limited information that I received, what I would rule in and what I would try to rule out. And I go over just a little bit about, what I would look at and what I've seen in clinical practice. And I also want you to think about, we may get situations like this where we have no other information, right? And you want to really challenge your thinking here. You want to think out of the box and try to ask yourself different questions each time. Okay, I hope you enjoy. Hi, everybody. This is Erica Mello, and welcome to episode number 170 of Tough to Treat. And in this latest episode, which is a shorty, by the way, this is a shorty week for us, is a patient scenario that was sent to me by one of our listeners. And Susan and I have been talking about doing this format every so often, where someone would send a very short patient scenario and, basically say, what would you do? How would you assess? Or I'm stuck at this point. What do you think I should do? Very sort of not like, a 5-page history, right? Clearly with a lot of these patients, you're going to need some more history, but these are things that you want to rule out. And I'm trying to give you some clinical pearls as to what to look for in this particular scenario. And if anybody wants to send us, it's a very short patient scenario, email us at tough2treatpt@gmail.com. So tough2treatpt@gmail.com. And we can, we'll pick one or two, maybe, every couple of months, and we'll see if we can give you our advice on what we would do on the air. So this was this person had chronic hip pain. It's a 32-year-old male, and it was his right hip. And the therapist gave me a short history, and it was primarily started from a groin injury 2 years ago. Okay, so very common scenario, right? Had PT, orthotics, NSAIDs, et cetera, with no help. One thing I would tell you is that when someone says they've had orthotics, it does not help, does not mean that the foot is not the driver or one of the drivers, because I've seen this scenario many times. The hip and the foot are critically related. And if it's not one of the primary drivers, it's definitely a secondary. We need to rule it out. Okay, you need to rule the foot out immediately with something like this, okay? And if the patient has said, I've had my foot treated, but they really haven't had their foot treated by you. And so that's just sort of one clinical pearl off the bat. So had the MR that had right hip labral, MRR of the right hip, which showed a labral tear. Once again, common. And complaining of pain in the adductor at the tendinous insertion. Okay, also common. So what you want to think when you have scenarios like this or any other persistent case is you want to figure out or determine what is the pain generator and what is the driver. They could be one and the same, but the longer the patient has had the symptoms, the more often than not, they are different. Is the pain generator the hip, the labrum? Potentially. Is the driver of the hip? Most likely not. Okay. So what you want to think about fairly often or fairly frequently when you have someone who tells you it all started when. So it was this groin injury 2 years ago. You want to know exactly what they were doing. Not, I fell off my bike. Okay. You fell off your bike. And how did you fall? How did you land? You want to be a detective. You really want the specifics for all of your patients, but especially with these types of patients, because it will show you how they have adapted. What were they doing at the time of initial injury? Usually with a labral issue, it's usually the hip is in external rotation and hyperextension a lot. So, you want to determine as best you can what they were doing. And by default, try to figure out what position their hip was in at the time of injury. Okay. In addition to the pain at the adductor insertion, he complained of a popping sensation. The therapist also wrote to me that he had limited hip mobility, didn't specify what motions, but we can all pretty much assume that it was probably internal rotation, flexion, adduction. That's just my assumption, though. Clearly, the patient has lost his hip centric mobility, or his loss of center. Muscle testing revealed 3 out of 5, pretty much all planes of movement. That is what I got. Okay, not a ton of information, but there's a lot that you can glean from initially. Okay, so you don't want to get sucked into treating what hurts if you don't have to, and if it's a waste of time. Okay, that's why you want to determine what the pain generator is, and then ultimately their driver. Susan and I, in all of the episodes, pretty much we've had, now we're at 170, I said, we've always talked about center of mass. Because this was 2 years ago, you want to determine how they've adapted. Is their center of mass to the left? It was his right hip. Is it on their right leg? How do they look when they're standing normal, narrow, wide? I didn't get any other functional mobility information from this therapist. So it was like, what would you assess? How would you look at it? So I'm going to give you a very brief, 4 or 5 very brief bullet points on what I would do, in addition to what I've mentioned already. And so when you have an injury like that, over the years, you're going to have probably some connective tissue damage. And the original injury, I mean, and you're going to have an issue with blood flow, right? So we all know blood flow to the hip. It's very common to have issues with blood flow, especially when the connective tissue doesn't generally receive the blood flow. Okay, and there are a lot of, especially in the shoulder, there's a lot of parts bony anatomy that tends to be avascular in a way. And so you want to think about initially, was there a loss of blood flow to the connective tissue if there was connective tissue damage? So you just want to put that in the back of your brain, because blood flow could be very important for healing. And if there was, a loss of blood flow at the time, the bone will certainly have adapted, and you'll be able to see that on X-ray. And in this particular case, they went right to MR, because it is mostly done with, especially if it's a suspected labral tear. They'll do MRA generally, but as far as I know, this person only just had the MR. Okay, so immediately you want to think about the GI system. Okay, and in our last episode 169, we talked a lot about the GI system as it relates to low back pain. In this particular episode, or this particular patient, you also want to think about the GI system. What's the relationship of the visceral system to your patient's symptoms? It's something that therapists don't always look at initially. Okay. We go straight for the biomechanics, which I understand. But when you have a persistent issue, let's think out of the box. You want to flag the chemical drivers to their chronic pain. Okay. And if you haven't taken any of the Labral courses with regards to visceral mobilization, I highly recommend that you do. Okay, even if it's the first couple of, I think it's VM1 or VM2, you'll look at possible visceral issues to somatic pain, right? So you can easily go in and palpate the pulses in the abdominal cavity. They're easily found. But you want to just flag that, because if it's a visceral issue that's causing this, no matter how much strengthening or stretching or mobs that you do, it won't generally get the patient better, because you haven't addressed this issue. Okay, so you want to flag that driver first. And with patients like this, it is always multifactorial or multifaceted, right? Okay, so the second sort of main issue that what I would look at, we talked about looking at what position the hip was in, if the patient remembers, at the initial time of injury. Okay, you want to flag the visceral system, right? If it's a connective tissue issue back 2 years ago when he suffered this, you want to think about, okay, was there a blood flow? Was there damage to the tissue? I would, as I mentioned in many other podcast episodes, taking an imaging course for my doctorate and getting my doctorate of science. And I'm almost finished, thank God. But this imaging class I'm taking has been pretty outstanding, I have to say. And I've learned a lot about, the importance of imaging and how it does relate to to your patient's symptoms, or how it does not relate. Sometimes, we look at images and we see things that are incidental, right? But it has opened my eyes to many other aspects of the patient presentation. As physical therapists, if the patient has had an image done, I believe it is our duty to at least acknowledge that and take a look at it. I mean, x-rays are going to be a bit easier, but you can certainly look at an MR and get a general idea of what's going on. And if you can't, I would suggest taking an imaging course. So you want to make sure that you acknowledge that in them, okay? And you need to tell the patient that, yes, the MRs, labral tears are very common, and most people have them and they are asymptomatic, okay? But is that the pain generator? Most likely in this case, okay? Next thing you want to do is a gait analysis. Okay, I don't mean a fancy gait analysis with markers. I just want to have them walk down your hallway, have them go forward walking normally. And what you'll normally see is on the same side of the labral tear, you'll see obvious, they'll shorten their step. They may flex the knee a bit. On the ipsy side, you'll see a little bit of knee flexion on the ipsy side. You'll also see them shorten their stride, okay? Have them walk with bigger steps. I mean, with a longer stride length, you'll see a lot of asymmetries there, okay? You may see some pelvic obliquity. You may see a unleveling of the hips. Then what I want you to do is I want you to have them walk backwards. The same thing, shorter steps, bigger steps. Okay, that's you will glean a lot from something like that. And that's not just to assess the hip, it's also looking at the foot. Okay, and so once again, the foot is definitely in play here, and I think that's would be on my diagnostics from the get-go. Okay, with regards to muscles, quadratus, obturator, a big muscle in this case, to release if that is relevant, as also quadratus femoris, and also the gemelli muscles. You really want to go in there and assess that soft tissue to determine if, yes, they have increased tone and whether it's worth it to release. Okay, if the pelvis is the driver. Okay, sometimes those muscles, are really, 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 I don't want to use the word tight, but there's a lot of hypertonicity there that may need to get released, even though the pelvis or hip may not be their driver. Okay, it's been there a long time. Sometimes if you treat the driver, let's say the foot, you may need to clean some soft tissue up in the area of symptoms. Okay, so common ones again are obturators and quadratus femoris gemellus as well. Okay, so those are the main is things that I would focus on given this information. The gait analysis is very straightforward. The soft tissue analysis is very straightforward. Okay, getting the patient's history is less so. Okay, you need to know what the position of the hip was at the time of the injury, if you can guess it, okay, or if you can get them to tell you. You want to rule out the visceral issues, as I mentioned earlier. Listen to our last podcast episode. You'll learn a lot from that. We've also done a few other episodes on visceral pain. You can go on our website, toughtotreat.com, and type in viscera or GI system or digestion or anything like that, and episodes with those keywords will come up. The thing is, you want to flag the chemical drivers, okay? Because there certainly can be. You want to flag the nervous system. I mean, ultimately, the nervous system is responsible for much, as we all know, right? So you want to flag those and you want to address them, okay? I wasn't given a lot of information here, so I would have more questions. What was done besides, the therapy and orthotics. You want to look at a functional movement. I love looking at squats. To be honest, I think it's a great movement to assess, to see how the patient has compensated. But you want to, as I said, rule out neural. You want to rule out a neural driver or a neuro, I wouldn't say neuropathic, but you want to rule out neural tissue as the pain generator. You want to rule out, connective tissue. as the pain generator, and you want to rule out the labrum as a pain generator, to start. And you also want to see if there is a visceral component. And so, that's sort of the advice I would give starting off the bat. Okay. And I'll, review it really quickly again. Okay. Once again, you don't want to get sucked into what hurts. Okay. The gait, just have them walk down your hallway, normal gait, bigger steps. With bigger steps, you'll see more asymmetry. And then you have them go backwards, same thing. Normal steps, bigger steps. Labral tears, you're going to see step shortening, and you're going to see probably some compensations at the knee, maybe knee flexion, and then at the foot. Okay. You want to know what the position of the hip was at the time of the initial injury, if you can get it. Okay. You want to rule out the connective tissue. Okay. Because if there was damage to connective tissue, which it sounds like there was, you want to look at blood flow. And that's also, you can easily assess that. Just go into and palpate pulses to start. Go in the abdominal cavity, palpate the pulses. Okay. Go in the femoral artery, you can probably palpate the pulse. You want to rule out the GI system and the relationship of the visceral system to your patient's symptoms. Okay. And you want to flag those chemical drivers. I would also add to that, because of what I've seen, is, it's very easy when we have an injury to offload the side of injury. It's what we do. We're human beings, we offload. It's very easy for the foot to do that. The foot it'll just push you off. Okay. The pelvis is less likely to do that. It's hard to sort of transfer the pelvis over. What I mean is, when we want to weight transfer, it generally begins with the foot. Okay. We don't know anything else about this patient. I would, as you know, ask a litany of questions regarding past injuries. Okay. If the patient has had a foot injury, it's on my radar, right? So I didn't get anything else from this therapist. So, the obvious is you need to know past medical and past movement history. That would really be very helpful. But given this limited information, you want to use clinical reasoning. Okay. You want to see if the patient absolutely has changed their center of mass. The foot generally is the first thing I would go to, because it's easy just to shift our weight off the foot. The next area or region of the body that we do that with is our thorax. Okay, where it's very easy to shift our weight via our thorax. We can just translate left, translate right, go AP, done all the time. Okay, and so those are two areas that you want to rule out. Okay, even though, let's say the patient had no, other injury. Okay. You want to look at the thorax, because it is a common region of the body where we can offload symptoms, and the same with the foot. Okay. Even though the patient's had the symptoms just 2 years, it is a chronic injury, and the person has adapted. Okay. The orthotics didn't help, probably because the center of mass was not addressed. Okay. You want to make sure that, the patient's obviously lost his hip center, quote unquote. And you put a pair of orthotics on somebody who still hasn't, been rehabbed properly, or hasn't found their center, or they're still, weight bearing on the opposite side. The orthotic's not going to do anything, right? You need to be able to get them centered. Okay. But once again, it really means, finding their driver. Okay. And with this particular patient, as I said, with this limited information, I would go down the list of things I mentioned, but I would also look at the foot and the thorax, and see how the patient adapts. Put them through some functional movement patterns and see what a common pattern is. Are they chronically offloading that right side? Are they chronically, limiting hip flexion, hip extension? Put them through a multitude of functional movements, even if you can't do this in the first assessment, and see if a pattern emerges. Okay, that would be my advice. And hope you enjoyed this episode. And once again, Susan and I are, we're looking into doing more of these. So Thank you again for being longstanding listeners of the podcast. And if you have any any questions, reach out to us, toughtotreatpt@gmail.com. And we would also love for the listeners of you who haven't left us a review, we'd really appreciate it if you could leave one on wherever you listen to podcasts. It really helps us in the algorithm. And for our new listeners, thank you for joining our network here. And go over to the website, toughtotreat.com, and you'll find all sorts of goodies over there, some PDFs that we have and a listing of all the episodes. Hope you enjoy. Bye.